Welcome, everyone. This is our sixth episode of the International Uveitis Study Group Grand Rounds. We're going through sort of a series of case-based learning, talking about major topics in ocular inflammatory disease, which eventually will become a textbook and atlas. This session is focused on toxoplasmosis, affecting the eye, which is one of the common and complicated issues. And we'll go through an overall thematic lecture discussing the major issues and then proceed to some case presentations of sort of typical to more complicated cases with discussions from each of our faculty experts. So we have many great experts on this call. And so thank you everyone for joining. We'll start with our thematic lecture from Professor Alejandra de la Torre. She is a full professor at the Universidad del Rosario and a great researcher and also one of our sort of committee members organizing this and the first editor of the eventual textbook. So thank you very much, Alejandra, for organizing this session and for giving this talk. And please proceed. Thank you very much.
Thank you very much, John. And hi, everyone. Today, we will discuss some pearls and clues for the diagnosis and treatment of ocular toxoplasmosis. And why is so important to know about ocular toxoplasmosis? Because 1/3 of the world's population has positive anti-toxoplasma gondii IgG, which means that 33% of the world's populations has been in contact with this parasite. Of these, 2 to 18% have ocular involvement. It is the first cause of posterior uveitis, and in some countries, it is the first cause of uveitis in general in adults and children. It can cause visual impairment and blindness. There is no ideal treatment because no medication eliminates tissue cysts. It is a typical recurrent disease and it affects the quality of life. So, ocular toxoplasmosis has a tremendous impact in patients suffering from this disease. One of the clues for the diagnosis is the clinical presentation. Immune control of the infections leads to a scar on the lesion. The immune system can control parasite, but it cannot eliminate them. They insisted in the retinal cells, so reactivations are frequent, often on the periphery of all lesions. As you can see here, a yellowish, white, creamy lesion that is an active lesion called satellite lesion, and it's produced by the invasion and replication of the tachyzoids in the neighboring cells, leading to inflammation and to destruction of the retina and choroid, as you can see here. Symptoms depends on the location. Posterior compromise, when there is a posterior compromise, retinochoroiditis or retinochoroiditis plus vitritis, patients can present myodesopsia, visual acuity decrease, blurred vision, and when there are central lesions, patients can present visual field compromise. When there is an extension of the inflammation to the anterior segment, patients can present pain, hyperemia, photophobia, and also visual acuity decrease. Children usually present more severe symptoms and more complications. They can be associated with strabismus, nystagmus, leukocoria, microphthalmos, and microcornea. Ocular toxoplasmosis is a posterior uveitis, and the most common findings is a unifocal, unilateral retinochoroiditis. The most common association is vitritis. It can also be associated with vasculitis and papillitis, and with with anterior uveitis that can present as granulomatous or not granulomatous uveitis with posterior synechia, fibrin, and iris nodules. Usually, when there is associated anterior uveitis, it is secondary to possible reactivations and inflammation in the posterior segment. It can also be associated with IOP elevation. Ocular lesions can be located on the macula, posterior pole, or periphery, so they can be anywhere in the fundus. Regarding the types of ocular toxoplasmosis, it can be congenital or acquired. Congenital forms have more common bilateral compromise. Usually more severe presentation are more frequent macular location. Acquired forms usually are more frequent unilateral, unifocal, and they can be anywhere in the fundus. Serology and avidity tests are used to support the diagnosis of a recent primary infection. No, serology is important. IgG is the clue for the old infection or contact with the parasite, and IgM reveals a recent infection. An avidity test, a low avidity test, is used to support the diagnosis of a recent infection. Regarding recurrences, they usually develop as a satellite lesions. As you can see here, an active retinochoroidal lesion at the border of an old pigmented scar. Usually, toxoplasmosis present clustering pattern of recurrences after acute episode, and previous use of systemic steroids without antibiotic or application of subconjunctival steroids injection has been associated with a high recurrences rate. In addition to the typical lesions, we can have also a Chiariellis phenomenon, neuroretinitis, multifocal and extensive retinochoroiditis, vitritis, light in the fog sign, or papillitis, between others. There are clinical differences according to the geographical origins. That's how, for example, European patients that are infected with less virulent strains, usually type 2 strains, present a Th1 and a Th17 deviated immune response with a higher production of interferon gamma and IL-17A, leading to a limitation of the parasite proliferation and a moderate retinal pathology, as you can see here. While patients from South America infected with more virulent strains present a deviated immune response not to Th1 or to Th17, but to Th2, leading to an uncontrolled parasite proliferation and a severe retinal pathology, as you can see here. One important clue in the diagnosis of ocular toxoplasmosis are also laboratories. The most used is ELISA test, IgG and IgM, but in atypical cases, we can also use PCR in ocular fluids or Goldman-Widmer coefficient, having a co-infection in atypical cases in 7.5% of cases. That's why it's important to use multiplex PCR. So for the diagnosis, clinical is the first clue, but also serology is important, IgG, IgM, and avidity test, and also molecular diagnosis, PCR, or Goldman-Widmer coefficient, which is an ELISA, local ELISA. Another important clue for the diagnosis are images that can reveal us the activity of the lesions or some additional findings, such as, for example, here, papillitis. There is vitreous or vitreous haze or cataract. It is important, and it's important to know where is going on in the posterior pole. Ultrasound images are useful. OCT images are also clue, and as you can see here, we can observe the complete alteration in all the layers of the retina, and also the compromise of the choroid. You can see here some examples of typical findings in OCT. You can observe here hyperreflective oval deposits on the surface of the inner retina, and with around hyperreflective deposits along the posterior hyaloid, with mirror images of deposits on the retinal surface, and also choroidal involvement. Here, there is an inactive lesion with atrophic scar. For the differential diagnosis, we can consider other infectious disease, non-infectious, and masquerade conditions. So in conclusion, for diagnosis of ocular toxoplasmosis, although the clinical presentation in OT is frequently typical, serology is useful to confirm the diagnosis and to provide information about the time of acquisition or onset of the infection. IgG are memory antibodies, and IgM reveals recent infection. PCR in intraocular fluids is useful to confirm the diagnosis or co-infections or differential diagnosis, mostly in atypical cases. Images are useful to determine the disease activity, follow it, and detect complications. Regarding therapies used for ocular toxoplasmosis, all these therapies has been used for treating ocular toxoplasmosis, all alone or in combination. In a survey about practices for leading uveitis experts, 24 different regimes were registered using to treat ocular toxoplasmosis. Regarding classic therapy for active lesions, it is a combination of pyrimethamine, sulfadiazine, and corticosteroids. An alternative therapy, the most common alternative therapy, is trimethoprim sulfamethoxazole. However, in a study from Sohailian et al., pyrimethamine sulfadiazine obtained higher percentage of improvement, especially in the degree of lesion size reduction and inflammation, but there was no statistically significant. Here you can see the doses of systemic therapy, classic therapy, pyrimethamine, sulfadiazine, prednisolone, and folinic acid. And for the most common alternative therapy, trimethoprim sulfamethoxazole. Regarding classic therapy, antibiotic and antiparasitic doses of classic therapy, they are based in prospective randomized single-blind clinical trial, but not comparing different doses. And in expert recommendation consensus, you can see here adult doses for adult and pediatric population. But what the best doses are, there is no evidence regarding which doses for each medications are the best. Concerning alternative therapies, adjuvant therapies, steroids is one of them. The steroids that should be used in combination with antiparasitic or antibiotics and adjuvant or additional therapies. But how about the steroids and recurrences? The use of systemic steroids without antibiotics and subconjunctival steroids injections has been identified as the main factor related to recurrences. So do not use systemic or subconjunctival steroids as monotherapy. Concerning combining alternative therapies for active lesions, we can have double therapy or triple therapy, quadruple therapy with clindamycin, or quadruple therapy with azithromycin. But the recommendation is to use alternative therapies only in non-complicated cases, or in case, for example, of allergy to sulfates. So we can have different therapies: systemic, intravitreal, and prophylactic treatment. We just saw systemic therapy, classical therapy, or alternative therapies, and here are the doses for classic and one of the most common alternative therapies, and they should be used until the resolution of the active lesion. In a study about safety and efficacy of different antibiotic regimes in patients with ocular toxoplasmosis, no antibiotic regime was superior to others. The selection of a scheme depends on multiple factors, so you choose based on safety, sulfa allergies, and availability. Intravitreal therapy. In intravitreal therapy, we can use the most used is clindamycin plus dexamethasone, and it should be used when there is an intolerance to oral medication, no response to oral treatment, in cases of pregnancy, or to avoid macular or optic nerve involvement. There is another alternative therapy with trimethoprim sulfamethoxazole plus dexamethasone, and we will discuss later on prophylactic therapy. Intraocular local therapies has some advantages over systemic therapies. This therapy avoids the need to cross intraocular barriers. It directly deposits a higher concentration in the intraocular environment. It has better intraocular penetration, better security profile, and it avoids the risk of intolerance of systemic therapy, and there is less need of hematological laboratories. But newly acquired IgM positive infection must receive systemic treatment. There is a case series about the use of sulfamethoxazole and trimethoprim associated with dexamethasone with good results, but triamcinolone is not the best option because the toxicity of this medication. Dr. Berfold showed us they have to suspend a clinical trial because this toxicity. Here are the doses for this therapy. Regarding congenital toxoplasmosis, although there is a positive benefit of postnatal treatment in congenital toxoplasmosis, in some cases it is very difficult to improve. Thus, prevention is the clue. And in congenital toxoplasmosis, if congenital toxoplasmosis is confirmed during pregnancy or at birth, treatment should be given with classic therapy for 1 year. Prophylactic treatment is important. The first line to prevent recurrences is trimethoprim sulfamethoxazole, half of the doses every other day. Prophylactic treatment reduces the risk of recurrences by 83% in the first year and 87% in the second year after starting the regime with trimethoprim sulfamethoxazole. An alternative treatment option is parametamine. This is published recently by Dr. Belfort groups. Parametamine plus folinic acid 3 times weekly. So, in conclusion, for treatment of ocular toxoplasmosis, prevention of recurrences is possible. There is no ideal treatment because no one can eradicate tissue cysts. But not to treat is not an option. Peripheral lesions should also be treated. Treatment is usually given at least 4 to 6 weeks. However, it should be given until the retinochoroiditis is entirely resolved. Steroids should be given only in combination with antibiotic or antiparasitic therapy. Thank you very much.
Great talk.
Yes, thank you very much. Good. So we'll be having a period for questions at the end of the presentation. So let's go on to our cases, and we really appreciate your contribution, Alejandra. So we'll start with a typical ocular toxoplasmosis case. And this will be presented by Dr. Varriera, the associate of Professor Justine Smith.
Good morning, everyone. I'm just going to put in full mode here. Just a second. Okay, and thank you for Dr. Alejandra de la Torre for sharing the case with us. So the clinical history of our patient here, it's a 15-year-old Caucasian boy that showed up at the clinic with blurred vision and a central black spot in his right eye for the past 5 days. There was no other ocular symptom associated, and he had a history of active toxoplasmosis in the same eye 2.5 years previous, when he was treated with sulfamethoxazole and trimethoprim associated with azithromycin for 6 weeks, and he also used the Deflazacort, which is a derivative of prednisolone with progressive tapering. In that occasion, 2.5 years ago, his vision went from count fingers to 20/70 after one year after treatment. And the boy was otherwise healthy with no other past or current medical conditions. His previous laboratory testing showed a positive IgG for Toxoplasma gondii and a complete blood count that was normal. So on his clinical examination, the right eye showed a visual acuity of 2400 with central scotoma, and the left eye was 20/20. His intraocular pressure was of 14 millimeters of mercury, and on the slit lamp exam, his right eye showed a slightly hyperemic conjunctiva, no anterior chamber cells, and 0.5 plus anterior, no anterior chamber cells and 0.5 plus anterior vitreal cells. And his left eye was unremarkable other than slightly hyperemic conjunctiva. The fundus examination showed a 1 plus vitreal haze with mild hyperemic optic disc with blurred margins and a whitish area of retinitis with some intraretinal hemorrhages adjacent to the pigmented retinal choroidal scars, some vascular sheathing, and a serous detachment more visible here at the red-free imaging. And here on the fundus autofluorescence, he showed those hypoautofluorescent patches in the old scars and a mild hypoautofluorescence in the active lesion with some hyperautofluorescence in the posterior pole and likely due to subretinal fluid. His left eye was unremarkable. On fluorescent angiogram, we see early hypofluorescence in the early phases with progressive hyperfluorescence of the margins of the lesion, achieving some fuzzy margins here with some vascular leakage in the late phases with also leakage from the optic disc. The left eye was unremarkable. In his OCT, here we have a horizontal and vertical section of his OCT. He shows some hyperreflective dots in the vitreous with a partially attached posterior hyaloid, a full thickness retinal hyperreflectivity, here nasally to the fovea, and some intraretinal, subretinal fluid, RPE thickening, and choroidal hyperreflectivity and thickening. And in the vertical section, we can see this preretinal deposit with thickened hyaloid and extensive area of subretinal fluid. The OCT of the optic disc showed some, again, hyperreflective dots in the vitreous with a preretinal deposit, hyaloid thickening, and we see an absent excavation of the optic disc, likely a reactive papillitis. The OCT of the left eye was unremarkable. The boy was prescribed sulfamethoxazole 800 milligrams and trimethoprim 160 milligrams every twice a day for 6 weeks. And associated with that, we used the Deflazacort 30 milligrams starting 2 days after the start of antibiotic therapy. for 2 weeks, and then with gradual tapering. The visual acuity of the boy 7 weeks post-presentation was 2400. So here are the fundus images of the follow-up of the case, 7 weeks post-presentation. We see some epiretinal membrane here and a more delimited retinochoroidal scar adjacent to the old scar here, and a mild pallor of the optic disc temporally. And here in his OCT, we see so this mild epiretinal membrane, the complete loss of foveal architecture and disorganized retinal layers, thickening and elevation of the RPE and Brooks membrane chorocoapillary complex with atrophy, and still see here some hyperreflectivity of the choroid and thickening. And on the vertical slab, you can see this RPE and chorocoapillary atrophy. 7 weeks post-presentation, the OCT of the optic disc showed now we can see the excavation of the optic disc within still partial posterior vitreous detachment here with some thickening of the hyaloid, and we see that there was the reduction of the thickening compared to the previous images. And here just comparing the presentation, the fundus photographs of the presentation and 7 weeks post-presentation. And the boy remained with a poor visual outcome with a vision of 2400. Thank you.
Good. Well, thank you very much. And now we'll move on to Professor Justine Smith's discussion of the case.
And I'm just going to share my screen. Here we are. So, hello everyone, it's great to be here and to discuss this case which Dr. Ferreira has so nicely presented, and we are grateful to Professor Della Torre for letting us share her patient for this talk. So I'm going to discuss the case in the context of some of the work that I've been involved with, but I just want to acknowledge that my fellow lecturers here at this Grand Round have published many excellent articles on ocular toxoplasmosis, and I've just here got one paper of each of my fellow lecturers that have recently been published that I really enjoyed very much, and so make sure you look up those papers. The other thing I want to do is make a couple of quick points before I talk about the case. We have to acknowledge that this is a very common condition. This is a study we did in Australia. Dr. Ferreira is the first author on it. We used some photographs that had been taken for other purposes. They were for macular degeneration and glaucoma screening, and through a process that involved consensus with uveitis specialists and serological testing, we were able to show that the prevalence of ocular toxoplasmosis is 1 in approximately 150 Australians. It's a very common condition in other parts of the world too. So where do you get it from? Mostly it's from eating undercooked or raw meat. This is a study we also did in Australia where we went down to the supermarket 3 times a week for 6 months, and we collected lamb mince and we tested that mince by PCR. We tested it for toxoplasma DNA, and we also tested it for bacterial DNA, looking at bacteria that are common contaminants of meat when it hasn't been handled well. And we didn't pick up any bacteria, but conservatively, about 40% of those lamb mince parcels had parasite DNA. And if we were a bit more liberal with our definition, it was close to 70%. And this finding would be consistent with a really nice study that was done some years ago in Europe in pregnant women, also showing that meat is the most common way to catch this nasty guy. Okay, but let's come to our case now and the presentation of typical ocular toxoplasmosis. So just like our patient, the most common symptoms are altered vision and floaters and in one eye. So it's exactly what this young man presented with. The patients can have a history of attacks, and they're often in their teens or they're young adults when they first present. Again, just like our patient. Genders are equally infected, and there are some environmental factors that might predispose individuals, and Professor Belfort's team have published work on this that's been most illuminating. And at the moment, the genetic studies are still pretty much in their infancy, and Professor Della Torre has worked in that area. Most of the patients with typical ocular toxoplasmosis are otherwise healthy, just like our young man. He had a very typical retinal presentation with necrotizing retinitis, that fluffy white inflammation adjacent to the pigmented scar from previous attacks. We talk about the headlight in the fog. So he didn't have that, but he did have a little vitritis. He had a trace of vitreous haze and he had some vitreous cell. Some things that you may find in a typical case include retinal vasculitis, which he had, choroiditis, a mild anterior chamber reaction. He didn't have that. And sometimes patients can have intraocular pressure elevation, which Professor Della Torre told us this chap didn't, however. So in terms of diagnosis, if we look to the IOIS survey that was published last year, you can see that approximately close to 60% of uveitis specialists use their clinical exam and toxoplasma serology to diagnose typical ocular toxoplasmosis, and that's exactly what was done for this patient. We had a past history of a positive serology and obviously now relying on the clinical examination. Dr. Ferreira presented some beautiful ocular imaging. That's not required to diagnose a typical case, but Professor Della Torre pointed out some of the benefits of doing it. And also, an OCT, for example, is very easy to get. And the more OCTs you do and the more you look at these, the more aware you are when you see an atypical case. And the scans that Licia presented showed some of the hyaloid and choroidal OCT signs that are particularly characteristic. So treatment of typical ocular toxoplasmosis, also looking to our survey again, you can see about 2/3 of uveitis specialists give trimethoprim sulfamethoxazole combination orally to patients with this condition. And the majority of IOIS members, uveitis specialists, will treat all patients, and that was a point that Professor Della Torre made, or at least selected patients. So again, here our patient was treated with trimethoprim sulfamethoxazole, so very, very standard treatment. And the patient also had some corticosteroids, some systemic corticosteroid given for a period to help with the inflammation. And that's also something that's done very commonly by uveitis specialists. And finally, what about the outcome? So we talk about typical disease, so that almost implies that the outcome should be good. But actually, the outcomes of ocular toxoplasmosis, even in a typical case, may not be very good at all. So this is data from a cohort study that we've been fortunate to collaborate with Professor Furtado from Brazil on. And it's a large series of patients, and you can see for 311 eyes, once the disease had become inactive, so it's quiet now, only about half of the patients were left with normal vision. And there were a quarter of patients who had very, very severe visual loss to the point of blindness. So our patient was left with 2400 vision, so down here. So yes, it's not good vision, but it's also common in typical ocular toxoplasmosis to not have a great visual outcome, unfortunately. So another reason that we need to be on top of this disease. And with that, I thank you for your kind attention, and I'm looking forward to hearing about the more complicated cases from our other lecturers. Thank you.
Good. Well, thank you very much, Justine. Justine, by the way, is a distinguished professor, Flinders Distinguished Professor at Flinders University in Australia, and former president of ARVO. So we're very happy to have your distinguished contribution to our seminar. So next we'll have an atypical ocular toxoplasmosis case by Dr. Ramirez Marquez, an associate of Professor Daniel Vasconcelos Santos.
Hi, good morning. I'm Laura Camila Ramirez Marquez, and today my advisor was Professor Daniel Vitor Vasconcelos Santos. We are from Universidade Federal de Minas Gerais. We are going to be talking about a 52-year-old Brazilian woman that came to us with an ocular pain and decreased vision in her left eye for 1 week. She was otherwise healthy. She didn't have any other previous remarks that we saw in her. For her ophthalmological exam, we saw that she has a visual acuity in her right eye of 20/20, and in her left one, it was 20/70. She had an increased ocular pressure just on her left eye. That was the one that was having troubles. And on her ophthalmological exam, the remarkable things were that she had multilateral injection, she had mild corneal edema, numerous granulomatous cavities, she had flare, 2 crosses, cellulars on her anterior chamber, 3 crosses, and she had cellularity as well on her vitreous, 3 crosses. On her fundus exams, we are able to see that she had a vitreal flare and haze augmentation, as you are able to see, but she had this large, really big, white necrotizing region upper to her optical nerve. So we did exams, and we were able to see that she has this hypofluorescent lesion in the same place that we were able to see the bigger, whitest patch that she had. And we were also able to see in the later stages of her EGF that she had a hyper fluorescence adjacent to this patch, black patch that she had. She had vasculitis, she had late liquidage. So in this moment, we decided that we were going to do an OCT. We did the OCT at her macular region, and she didn't have any really remarkable besides the augmentation of the cellularity that we were able to see, these white dots in her vitreous. And we decided to make these scans as well at the white patch that she had superior to her optical nerve disc. We were able to see in these scans that she was having fusiform thickness of the retina that we are seeing here. She was having hyperreflectivity of the inner layers of the retina. She was having loss of the retinal striations. She was also having bumping of the RPE, which is the green one that we are seeing there. She was also having interrupting of the RPE. She was having a choroidal thickness and hyperreflectivity that we are seeing here. So this is the patient that we had, a middle-aged woman with decreased vision and a higher intraocular pressure. We had 2 possibilities. So we decided, what are we going to do? We have the possibility that she was having an atypical toxoplasmosis because of the larger lesion, or she was having a necrotizing herpetic retinitis. So we decided that we was going to begin with the classical treatment for toxoplasmosis, but without the hair search because we weren't certain if she was having an herpetic type of thing. And we did the treatment for herpetic type of thing. We asked for serological tests, and we decided that we were going to be doing an AC tap as well. On day 7 of this treatment, combined treatment, we saw that she was improving with her vitreal haze, and it was even better to see the limits of the lesion. She came back to us with a negative HIV, but she was IgG positive for toxo and herpes simplex and zoster as well, but her PCR on her AC tap was negative for toxo and for herpes virus. So we were more chill to be able to begin with a steroid therapy. On day 14, we were able to see what you are seeing here. It was more easy to see the lesions. It was more defined. It was improving. Vitreous was responding very well. So on day 45 of treatment, she improved, but we remain with the basic question. This is the AGF that we made control. She had a window defect on the side of the region, and we were able to see here now that she was having the residual things that we are going to see here in her OCT. She was having thinning and disorganization of the neurosensory retina. That is the pinky thing that you're seeing here in the upper part, like in the down image. She was having thinning and a hyperreflected choroid as well in the same place. Also, so in this moment we need to ask this question: it was an atypical toxoplasmosis or was it herpes? And we have the response 6 years later. She came back to us because she was having a difficulty with her vision in her left eye as well, because we made the exam and she was 20/60 on that eye. And she had this remarkable thing. She was having an emotional distress because she lost her mother in a building colliding. So we were seeing now this lesion that is more like a typical toxoplasmosis, as a skeletal lesion adjacent to the previous one that we saw, but this time it was more organized, but it has the typical things that toxoplasmosis has. So we decided that we were going to be an alternative treatment with azithromycin pyrimethamine, and we began more easily with the stereotherapy. 3 weeks into the treatment, she was 20/30, so the vision was improving. And at the end of the treatment, she was 20/20, and as we are able to see, the lesion, the white patch satellite to the primary lesion, it was improving. It completely improved. So we were more eager to say that it was typical toxoplasmosis in this time. We are seeing here a window defect on her AGF and on her control, and we decided because of the emotional distress we should consider prophylaxis for her, but she decided she didn't want it, so we stopped it. She came back to us again 6 weeks later. She was 20/20 as you were seeing, but now she was 20/25. And as we are seeing the satellite part that we were seeing again, it began to grow again. It was wider, it was a little bit bigger. So we did the alternative treatment again with azithromycin and stereotherapy, and we enhanced the possibility of beginning prophylaxis with Bactrim 3 times a week. And that's what we did. She improved. So the final remarks in this type of history is we need to remember that ocular toxoplasmosis is a recurrent disease. That atypical type of presentation are large, like it was in this patient, but it can also be multiple active lesions, which we are going to be able to be thinking about necrotizing vector retinitis. We must consider this as well in patients with predisposing conditions as immunosuppressive states, HIV, chemotherapy, inadvertent use of steroids, and recent seroconversion for toxoplasmosis. And here we had this study that it was made here in Belo Horizonte. We had an outbreak of toxoplasmosis, and this atypical type of patient, as these images are really alike as the one that we had. If you are seeing are these really large and big lesions necrotizing that don't remark like a typical toxoplasmosis. And we saw that in this type of patients, the recurrence was really high, it was higher. So the prophylaxis was more important in this type of patients because the recurrence is higher, as you are seeing the Kaplan-Meier in the lower part of the image. So molecular testing for ocular fluids, they help us to rule out herpes to begin steroidal therapy more easily, with more ease, but they don't rule out, even if they're negative, the toxoplasmosis. So that's why we continue with the treatment. Multimodal imaging for differential diagnosis and for follow-up are incredible in this type of patients. The clinical pleomorphism is really different in recurrent episodes, and we really need to be thinking in this type of patients to be doing a secondary prophylaxis. And that's all. Muito obrigada.
Fantastic. Well, thank you very much. And let's move on to the discussion of the case. We welcome Professor Daniel Vitor Vasconcelos Santos, who is Associate Professor and Chair of the Department of both Ophthalmology and Otorhinolaryngology at Universidade Federal de Minas Gerais. I hope I'm pronouncing that right, in Belo Horizonte, Brazil, and one of the excellent leaders in our field. Thank you for joining us, Daniel, and we look forward to your talk.
Thank you so much, John, for this kind introduction. Congratulations for this wonderful IUSG initiative. you, Alejandra, Vishali, and Rima, all of you guys are doing great work in publicizing the importance of uveitis globally. Congratulations, Laura. That we chose that case because it has many interesting features to discuss. It's not difficult to make the diagnosis of typical ocular toxoplasmosis, as Alejandra Nice pointed out in her presentation. It's typically a focal necrotizing retinal choroiditis. The issue we have is to diagnose atypical cases. And here we have listed the most common atypical presentation of ocular toxoplasmosis: toxoplasmic neuroretinitis, the so-called punctate outer retinal toxoplasmosis, and the more aggressive retinal choroiditis that may present as multifocal or even extensive fulminant retinal choroiditis, which may simulate a herpetic kind of picture, as Laura pointed out. More rarely, we do have the so-called frothed branch undeitis, and even very interestingly, the so-called intraocular inflammation without apparent retinal choroiditis. Professor Belfort's group described that in a very interesting study in the south part of Brazil many years ago. What is interesting is many of these forms of presentation that they do have predisposing contexts. So as immunosuppressed individuals for more fulminant toxoplasmosis, it's very easy to understand, because once you have a depressed immune system, the parasite may grow freely and may lead to more extensive lesions. So anytime we do have a patient with fulminant type of presentation, we may think about the possibility of immunosuppression. For neuroretinitis, I just decided to bring this picture because multimodal image is something that we're using a lot. And specifically for toxo neuroretinitis, that may be quite useful because you can document the focal reactive choroiditis that we do see in these cases. And these many times help us differentiate toxoplasmic neuroretinitis from, for example, Bartonella neuroretinitis, as a matter of fact. The punctate outer retinal toxoplasmosis that form in which we have exudation to the outer retina with exudative retinal detachment, sometimes multiple small infiltrates. And this is the context of our talk, the so-called more extensive fulminant type of lesions. Anytime we see a patient with aggressive, large foci of focus of retinitis, retinal choroiditis, we have to entertain the possibility of some sort of immunosuppression. So all these patients do deserve testing for HIV. This is an example of a patient that came to us with loss of vision in her left eye, this extensive fulminant multifocal retinal choroiditis, and she had HIV, which was not suspected before, and the PCR was positive for toxo in the aqueous humor. This is the other predisposing context, which happens to be recent seroconversion for toxo. So in outbreaks all over the world, we haven't seen patients with some more fulminant forms of toxoplasmic retinal choroiditis with these atypical presentations that we hypothesize this is possible because the patient is not still yet able to mount a robust immune response to contain infection. And so the patient may have multiple large and even bilateral lesions, as we see in this case here. Immunosenescence as well as an issue. So elderly of the immune response may also have more aggressive forms of presentation of toxoplasmosis, which may be mistaken for herpetic disease, as Laura pointed out. And last but not least, the so-called frosted branch undeitis. This is a case of a patient we saw many years ago here in Belo Horizonte with this diffuse vasculitis. And once we started to treat her, then she started to localize this lesion supratemporally to the optic nerve, which was tomographically very suggestive. Toxo, she was treated and she finally responded. And the last form of presentation that I would like to stress, also because we do have Rubens here in the board, is the so-called multifocal punctate retinal choroiditis. We have seen this in two most important situations. First, in children with congenital toxoplasmosis, if we examine these children very early in the first days of life, sometimes we do see lesions in the macula, as you see in the right eye of this small child, but many times we do see peripheral, very mild retinal infiltrates, which we hypothesize may represent the first entry of the parasite into the eye. But we have also seen this type of pattern in adults with recently postnatally acquired toxo. So this is from that paper that Laura showed recently. It's a patient that came to us. He had fever, malaise, generalized lymphadenopathy. Vision was 20/20 in both eyes, and only because we carefully looked at his periphery, we did see these multiple whitish infiltrates in the retina, very similar to the ones we just showed for congenital toxoplasmosis, that this may be easily overlooked. So we do think that sometimes there is some retinal involvement, very mild. We cannot see if we do not very carefully examine these patients, and these may represent the first entry of the parasite inside the eye. Rubens has reported this many years ago, the so-called intraocular inflammation without apparent retinal choroiditis, either for anterior uveitis, retinal vasculitis, isolated vitritis. We have seen a few patients with granulomatous anterior uveitis in the context of recently postnatally acquired toxo, but it's a very rare form of presentation. We really think that might represent cases in which there were very mild peripheral infiltrates which had been overlooked. This is another case from that outbreak that Laura has just showed. Is a patient with mild infiltrates in one eye and a large necrotizing lesion in the left eye. So what was very interesting about this paper was that we did see that the patient with more severe forms of presentation did have much more often recurrent disease after we follow them up for long term. So it's likely that we should manage these patients with secondary prophylaxis. And that's what we decided to show and to discuss. So the last word I would like to say is on the utility of molecular testing. In contrast to what we have for herpes viral disease, the sensitivity of aqueous humor PCR for toxo is not that good as 40 to 50%. So a negative PCR of the aqueous humor for toxo does not rule out toxoplasmosis. A positive result does confirm it. However, for herpes viral disease, it is very sensitive. So usually when we are facing a patient with aggressive retinal choroiditis, the typical ones that may be the presentation of herpes viral disease, we usually tap the aqueous humor and order the PCR. If it comes positive for viral, this is viral. If it's negative for viral, even for toxo, as Laura showed in her case, this is most likely the possibility of toxoplasmosis. This is what I would like to say, and finally invite you. Next year we're having the International Ocular Inflammation Society Congress in Brazil, in Rio de Janeiro. So all of you will be more than welcome. Thank you so much, John, Alejandro, and congratulations for this initiative.
Thank you kindly, Daniel. So that's great. And just the kind of things that we're trying to emphasize in this session. Our last case is ocular toxoplasmosis with treatment challenges, presented by Dr. Guilherme Macedo, an associate of Professor Rubens Belfort. Thank you. Please proceed.
Hello, everyone. Can you see my screen?
Yes.
Okay, so I'm Guilherme Macedo. I'm going to present the third case of our meeting. My advisor is Professor Rubens Belfort, but we have to give special thanks to Professor Ana Carolina Macedo, Maria Cristina Martins, Cristina Mucioli, and Miguel Bournier. So we have a 58-year-old male businessman, white, born and raised in São Paulo, complaining of a progressive vision loss, redness, and pain in both eyes for a week, mainly in the left eye. His past medical history, he referred only smoking, and his past ophthalmologic and family history were unremarkable. In the physical exam, he presented in the right eye the CVA of 20/50, the intraocular pressure of 25, a mildly hyperemic conjunctiva due to ciliary injection, a clear cornea, 2+ anterior chamber cells, flare, 2+ vitreal cells, and 1+ vitreous opacities. In the left eye, an important ciliary injection, BCVA of 2200, IOP of 36, this diffuse corneal edema, 3+ anterior chamber cells, flare, 2+ vitreal cells, and 4+ vitreous opacities, and this posterior synecdoche. In the fundus exam of the right eye, we can see this extensive yellowish with ill-defined margins lesions due to a necrotizing retinitis, and this vasculitis with these ghost vessels. The fluorescein angiography highlights the extension of the vasculitis. The fundus exam of the left eye was impossible, but we can see here this alteration of the echogenicity of the wall and the vitreous adhesion, which suggested a focal of posterior uveitis as well. So for diagnostic hypothesis, we have a bilateral acute hypertensive posterior uveitis. In the right eye, we can see a focal necrotizing retinitis and vasculitis. In the left eye, the fundoscopy was impossible. Thinking about the etiological hypothesis, here we always initially think about infectious diseases. As we have a bilateral posterior uveitis with hypertension, we thought about a viral etiology, something in the spectrum of acute retinal necrosis, but we must rule out syphilis and tuberculosis. In Brazil, always that we have a focal necrotizing retinitis, we must think in toxoplasmosis as well. But obviously, we don't think in toxoplasmosis when we have an acute bilateral posterior uveitis. Sometimes we have like an acute uveitis in one eye and we find a scar in the fellow eye. But having a bilateral acute uveitis is not what you used to see in toxoplasmosis. Inflammatory causes of vasculitis and retinitis, we have sarcoidosis, Behçet disease, and also ANCA-associated vasculitis. And also masked syndrome was a possibility. So for the management, initially we thought about controlling the IOP. We obtained that with topical drugs, and we also performed a iridotomy in the left eye. And while we were waiting the etiological investigation, the lab's results, we started intravenous acyclovir for 14 days, and then we used oral acyclovir thinking about a viral etiology. As I said, we have a bilateral hypertensive posterior uveitis, so we initially thought about a viral etiology. The HIV and syphilis tests were negative. The patient presented a positive IgG for toxoplasmosis and negative IgM. The tuberculin skin test was 0, chest CT normal, and dermatological panel was also unremarkable. During the time that the patient stayed in the hospital, we started oral prednisone 1 milligram per kilo per day. This patient evolved well. After 40 days, he presented BCVA of 2040 and 2060. The IOP was controlled. But during the following month, the patient was still using oral acyclovir in maintenance dosage. The patient presented a bilateral recurrence. In the right eye, we can see this granulomatous KPs. In the left eye, we also have these small KPs. In the right eye, we have new foci of posterior uveitis, new foci of retinitis, and this increase of the previous retinitis now with some hemorrhages. Now we can see the fundus exam of the left eye. We have this very similar to what was presented. This next to the disc, we can see this extensive retinal lesion, this extensive exudative necrotizing retinitis associated with vasculitis. At this point, we added sulfamethoxazole trimethoprim twice a day, thinking about a possible ocular toxoplasmosis. Unfortunately, after 1 month, this patient started complaining of loss of weight and cervical lymphadenopathy. A new clinical workup was done, and we found cervical lymph nodes, bone, and liver metastasis of an undifferentiated squamous cell carcinoma from an unknown primary site. And this patient passed away 3 weeks later and donated his eye for research. So now we have the anatomical pieces. In the upper pictures, we can see the thrombosis due to occlusive vasculitis. And in the third picture, we can see the cysts, the T-gone cysts, confirming the etiology of toxoplasmosis, which was ocular toxoplasmosis. We can see here the T-gone cysts. Let me point. I don't know if you can see my pointer. It's here, you can see the T-gone cysts inside the retinal tissue.
Yes, we can see the pointer.
Great. And here with the IHC, the T-gone cysts. So, as we saw in the previous presentation, and we can find in lots of publications, toxoplasmosis can mimic viral etiology. We actually we had this misdiagnosis initially, and we started to treat this patient as it was a viral etiology, and later we have the confirmation that it was ocular toxoplasmosis. We have few publications showing how we can find the cysts in the retina. Here in the picture E, you have very similar images. We have the tissue cysts of the T. gondii, and also we have the thrombosis due to occlusive vasculitis. That's it. Thank you.
Very good. Well, thank you very much. And lastly, we have the discussion of this case by Professor Rubens Belfort Jr. And it's sort of difficult to think about ocular toxoplasmosis without thinking of Professor Belfort. He's published so much about it. He's something like the father of ophthalmology in Brazil, and long time, more than 30 years, I think, head professor of ophthalmology, like department chair at Federal University of Sao Paulo in Brazil. And we're very honored to have you join us, Rubens. So thank you very much, and please proceed.
Thank you, John. Thank you so much for being invited and also for all the good work you do internationally and locally for so many years. Well, better to say that maybe I'm the great-grandfather of Brazilian ophthalmology. There are many generations after me, actually better than me. But it's an honor also to be here with Alejandra and under this program, under your coordination and Alejandra's, and having Justine and Daniel with us, as well as this great idea of inviting young fellows. So one of the reasons we have chosen this patient is because I believe there are some lessons to learn from it. You may wonder why we did not ask it PCR and other molecular tests. Well, because this is a kind of old patient, and we decided that it would be nice to discuss it here and try to emphasize that we have now new things to do in patients like that. Also, second lesson is that we are lucky in receiving the eyes after the death of the patient. And this is something that we are trying to do more and more. And this special case to present to the family the possibility of going ahead in science and in medicine if we get sometimes specimens after the death of them. So this is some lessons I think are important. Next one, please. We believe that, as I said, we have advanced a lot regarding diagnosis in the last years. And we still have a lot of things to do. And I believe that we should continue to stress the importance of doing research, not only imaging and clinical work, but research and basic research and clinical research in each patient we see. It's very important. PCR is a big advantage, but there are many other molecular tests that I believe should be being done also, as in toxoplasmosis, and we're trying to do it in exosomes and other types of vesicles that may tell us a lot. We've seen, for instance, patients with inactive retinal lesions, and clinically would be by sure inactive. And when we do the PCR in the retina because of late vitreoretinal complication, we find a positive PCR. And we've seen it, I believe many of you have, and we do not know exactly the reason for that. We do not know, as far as I know, how long does positive PCR remains in the vitreous after the inflammation is over. Where does it come from? Is it possible that it's inside the eye because it comes in circulating cells, or there are other possibilities? Next one. As I said, diagnosis continues, and this has been stressed by all of the previous presentations that were excellent, all of them. Diagnosis, of course, is still based on clinical picture and laboratory, but we should go further. Blood is not enough. Go back, please. And anterior chamber tap, I believe, should be done more than we do. Antibodies studies in anterior chamber and the vitreous compared or not to the blood levels have not really advanced in the last 20 years. But PCR and other molecular tests are much better. They also bring new challenges and discussions. And Alejandra de la Torre, as well as our group, have identified that in some of the patients you do PCR for toxoplasmosis and toxoplasmosis comes positive, also Epstein-Barr is there. Is it possible that maybe Epstein-Barr or other virus would have a role in patients with active toxoplasmosis? We don't know. Next one. And when we have patients that we discuss it, we see very easy that we have not only direct action of the toxoplasma causing necrosis, but also the role of hypersensitivity and immunology mechanisms in the chronic inflammation. Next one. And no doubt more research is necessary. And maybe using these molecular biology techniques also, we're going to be finally able to differentiate strains. We all have, we all know, are very excited many years ago when we have type 1, type 2, type 3, and unusual strains. And after a few years, I start to say, no. We have type 1, 2, and 3 as unusual strains because most of the strains we have in Brazil are what they call unusual. So we have a lot of things to do regarding that. And again, molecular biology would be an important avenue. Next one. Of course, some of the cases are easy, such as this one. Next. But why? You have such a variety of clinical pictures. We do not see as much toxoplasmosis in the Amazon as you see in the south of Brazil, but usually the lesions are much larger, and maybe this related to the strains we have in the Amazon, kind of wild strains. Next one. Also, it seems that patients in the Amazon have a much more clinical picture that is similar to acute retinal necrosis than in other parts of Brazil. Next. And again, the role of hypersensitivity, the role of immune mechanisms has still to be better understood. We do not know if this is just because of hypersensitivity or we still have active organisms there. Of course, that I agree with all the previous speakers that we should cover them with all the antitoxin drugs we have, but we're not sure. Actually, that we've seen patients that were not well treated and received just steroids and did very well. So again, we know much less than we should, and I believe less than we believe. Next one. Also, it's been very important to recognize more and more that some patients with infectious disease develop anterior uveitis that in the past were not related to these infections. And the Fuchs is a good example of it. Ocular toxoplasmosis, rubella, cytomegalovirus, Ebola, and now also some patients with new viral entities present as anterior in a specific uveitis. Next one. The last line of this slide is what I want to call attention a few. Yes, we've been talking and relying that the recurrence are related to retinal cysts and toxo present in the retina, but is it possible also that some of the recurrences are related to systemic toxoplasmic organisms or maybe lymphocytes that carry on antigens and antigenic material inside the eye? We don't know. We know that parasite, the host, and the environment, the three are very important, and usually they are together and causing the uveitis that sometimes it's easy to diagnose and sometimes behave different than we would expect. Next one. So that's the final one. We still have a lot of things to learn, a lot of research to be done. And I go back to what I said in the beginning. Congratulations to all of you for organizing this program and having young fellows aboard. Thank you so much, guys. Have a nice weekend.
Thank you kindly, Rubens. So next we'll move on to discussion and controversies. Would you like to lead this, Alejandra?
Yes, so we have a pretty hectic Q&A session, and thank you for all of you for the great presentations. So I think we have many questions. Already are many answered, but there is another ones that but Daniel is typing. Would you start treatment? Also, Daniel is typing treatment for recurrences. One of the most controversial or more doubts are in the prophylactic treatment that should be used in patients with recurrent forms of the disease. More than two recurrences, more than one recurrences in 2 years, or when there is a threatening lesion close to the macula or in the optic nerve. But how long? This is a very controversial topic. How long? At least 2 years, because the clustered pattern is more frequent of recurrences is more frequent during the first 2 years, and because the reduction of recurrences has been reported to 83 in the first year and 87% in the second year. But the question is, do we have to treat the patients all their lives? We really don't know. So, but at least 2 years. I think, and I would like to have this controversy with my colleagues here, Daniel, Rubens, Justin. How long do you use this therapy, Rubens?
Well, that's a very good question. 2 points. First, for patients that do not receive Bactrim because of allergy, we just published a paper that we
Yes.
tried just pyrimetamine. So that is some controversy that we really need both drugs or not. I don't know. So sometimes we do it, and you're right. There are some studies showing that the first years after the IgM positivity are the worst, but we don't know how many they are, 5 years, 2 years, 10 years. And we did that study that was published in the south of Brazil. We published the first paper showing that, yeah, there was a 75% of protection. Great, they stopped it. We went back to the same population 10 years later, and it seemed that they had the same rate of recurrence that the untreated group. So is it possible that the treatment just helps? Why they are taking the drug? I don't know. I have a patient that I started to treat as a medical student, and now he's a very well-known physician in Brazil. Actually, he's specialized in infectious disease. Said, "I'm gonna take it the whole life." That's it.
Yeah.
Who knows?
Yeah. This is a very important topic, and thank you, Rubens, for publishing the article about parametamine, because after that we just had only the possibility to to use Bactrim, but now we know that parametamine it could be also useful. So for patients
Alejandra,
with allergy to sulfurs.
Yeah, but sometimes people trust my papers more than I do. So yeah, take in consideration. It's not because they're my papers that I rely on them more than the other. I'm always very cautious about what I publish. Please don't take this as a final answer. Right, John? John agrees with me. Everybody agrees.
Yeah.
Daniel is going to interview to say something, but before you Daniel, I will say that we should use this therapy in also in children, because there is a question there in the Q&A section, and I'm using in also in children. But and the thing that we should be careful is with following the patients with hematic studies and liver and renal function every 2 or 3 months. So go ahead, Daniel.
Well, that's a great discussion. Just 3 very brief comments. First, on the, as you nicely pointed out, the natural course of disease studies have shown that the toxoplasmic episodes, they do happen in clusters during the life.
Yes.
So we are looking at children with congenital toxoplasmosis, usually from 4 to 5 years of age. They do have clusters of recurrences. That's usually when we follow them more closely. But who knows? Anyone has this own immune system. It may behave differently for each patient. But so the studies show that in the first year, the risk of reactivation in the year following the most recent episode of active retinal choroiditis, the risk is around 10 to 15%. So that's not negligible. I mean, that's not, we should not ignore this. In the second year, it goes down to 5%. So usually what I do share this decision with the patient. I'll tell him or her, you have like a 10 to 15 risk of having a reactivation in the following 12 months. So do you want to it depends also on the experience of the patient with the therapy, with the treatment. Some of them do have severe side effects. They don't like to take corticosteroids. During the pandemic, that was a significant issue because they were afraid of getting COVID, taking steroids. So I usually share this decision. And my aim is to treat for 12 months, that is when the risk is higher. And after the experience of 12 months, I sit with the patient again and rediscuss. Do you want to extend for more 12 months? We do have around 5% risk. Most patients, they do agree with the second year. Some, they do not. Just some years ago, I did see a patient. He's a radiologist. And he has a congenital glaucoma in his right eye. So he's blind in the right eye. And in his left eye, he had an active vision in the macula of his only eye, functional eye. And so I told him, and he told, then I want to treat for my whole life. I'm very stressed out. That was just before the pandemic. And so I treated him for 3 years. Then he scheduled an appointment with me. He came back and, I'm fine. I think I can stop it, and it's all right. So I think that just to finish, prophylaxis is something that we probably talk about more and more in the next few years, because we are increasing this shared decision with our patients. And many of them do prefer to take the medication in a prophylactic manner for a longer time to make sure that they will not have a recurrence in the near future. So that's what I would like to say. Unless on the alternative of alternative therapy for prophylaxis, Ruben's work is great. I think it's something to consider. Pyrimethamine. The issue is the CBC monitoring, particularly in children, because they are increased risk of neutropenia. In our cohort with congenital toxo, 30% of the children with congenital toxo do develop neutropenia taking pyrimethamine. So we have to be very careful. It's not to prescribe and leave the patient alone. But we have some clinical experience, Rima McLeod from Chicago as well, with azithromycin. So we use it twice a week, and it's apparently safe. We have to look retrospectively at our data, but at least for our sulfa-allergic patients, it has been of help.
Yeah, about azithromycin, it could help, but in the systematic review we have published in PLOS journal, we found that azithromycin is the medication that less reduce recurrences, but more research is needed in this term.
So I have
John, Justin, and Rubens.
Just a short comment. I'm sorry.
Go ahead.
Yes.
Okay, just a short comment. Especially in non-verbal children, it's a nightmare. 3-year-old, 4-year-old children that not say, "Mom, I'm seeing less than before." These are the very high priority group with all this advantage, but these kids need to have chronic treatment to avoid the nightmare of seeing them after 6 months having lost the only eye vision. So especially in children, I think it's mandatory to do this treatment. Thank you so much.
Thank you. Thank you.
I have a question for the panelists. Does your approach change if you have an IgM positive versus when you have IgG positive? I mean, would you go for MRI for toxo in the brain or any neurological or because you need to eradicate the toxo from elsewhere in the body, not just the ocular. So would your approach change depending upon IgM, IgG positivity? Anyone from the experts?
Yeah, well, can I answer this one?
Yes, yes.
So at least like the experience shows that if the patient is immunocompetent, the likelihood of cerebral toxoplasmosis is very low. Usually it's an issue in patients with immunosuppressed ones, HIV. Having said that, we have an additional issue is that usually by the time the patient comes to us with the positive IgM, there have been several weeks of seroconversion. That paper that I showed that we published in Emerging Infectious Disease many years ago, we did look at the peripheral blood of the patient. We collect the peripheral blood. We did inoculate in mice. We did test PCR, and all of them had negative PCR, negative mice inoculation, because they are immunocompetent. So they are able to build quickly an immune response to contain the parasite peripherally. So we haven't seen a case of, that has been described in the literature, like in some highly endemic areas, patients with fulminant cerebral toxoplasmosis associated with recently acquired disease. But that is a very rare in immunocompetent patients. I think for HIV positive individuals, for the ones which are immunosuppressed, that may become an issue.
Good. I was just going to say a few more words about the secondary prophylaxis. If I remember correctly, when Gary Holland gave his Jackson lecture on ocular toxoplasmosis, he described what I sort of took as a sort of exponential decay of the viability of the organisms adjacent to the scar. So like the longer it is since the latest attack, the less the chance will be, which Daniel sort of said something like that for years 1 and 2. And so, you need to you can think of it in that framework in terms of the risk. And then I think it's probably obvious, but, patients who are immunodeficient or have multiple recurrences, you probably want to just go ahead and do secondary prophylaxis and just plan on doing that. So that's sort of an important consideration, as well as the young children, like Rubens was telling us.
Thank you, John. I agree.
Justine, were you going to say something?
Oh, well, I was just going to say that I also practice a 1 year treatment if I decide that someone's going to have prophylaxis, but I have a very low threshold to continuing it. And I have this discussion with the patient. And in Australia, as in actually many other parts of the world that you guys are working in, you have to think about how easy it is for the patient to come in. And if a patient's lives at a remote location, then I probably have a particularly low threshold for leaving them on it for longer. But I sort of have that assessment some patients are on it for years, as Daniel was mentioning too. So sort of just having that discussion on a yearly basis, I think.
Yeah, thank you. So we'll see if there is an interesting question, but Daniel is answered. The mechanism of secondary Fuchs syndrome developed in ocular toxoplasmosis.
Rubens will be the ideal one to respond that one.
Yes, is ocular PCR in HIV toxoplasmosis negative also?
Say again. What is the question?
The question is ocular PCR in HIV toxoplasmosis negative also?
Well, maybe negative, depending on the patient. Usually when we do PCR, we do the whole panel. So we do all the herpes viral and toxo, and also trying to do for mycobacteria It's not specific, but I believe it helps. But there is also another message that I think is very important to forward to everybody. We need more clinical trials. It does not have to be international clinical trial with 10,000 patients as the drug companies do for retina, but small clinical trials may add a lot of knowledge. So azithromycin is great. We should try for it. We need better drugs. And the only way, and we all know it, and having Justine aboard is even more important. We need more research. We need clinical trial. We need to go beyond just the presentation of clinical cases in our meetings. Thank you.
Yes, I totally agree. And we have here one of the most important persons in clinical trials around the world, that is John Kempen. John, please help us to do to do.
And maybe this would be a challenge for the IOSG to have awards for people that present clinical trials. John, does not have to be a perfect one. Doesn't matter. We're gonna learn. We're improving the techniques of doing it, but have a special award, a special session for, I don't know, poor and dirty clinical trials, but let's go ahead on that. It's the only way to advance.
Yeah, well, happy to discuss with people. Often they're so difficult to do, but I like to point to some of the ones originating from Brazil about secondary prophylaxis for this disease, because they have often been done with sort of very little funding and at one center, and since the effect is so good, they've been able to show a significant difference, and so that can be really useful.
Yes. We should do it. I totally agree with Rubens. We need more research and very large clinical trials. So we are here, the expert in talk, so we should do it. It's not easy, but it's necessary.
And congratulations, we are over 200 people already with us. 200. Congratulations, Alejandra, John.
Thank you for it's because you. So there are some other questions here. In the case of intravitreal therapy.
Yes, so I'm going to ask Rubens a question because I really like this concept that you might be infected twice or more with different strains of toxoplasma. And I don't know if there's anything more you'd like to add on that, Rubens, whether you have thoughts about, clinical manifestations or things that have made you think maybe that patient has been infected with a second strain. But it's a really interesting concept.
Well, it's an intelligent question, and the short answer, I have no idea. I don't know.
Okay, well,
it's a very important question. We should go further this line also. As well as what Alejandra pointed out, possibility of having mixed infection. We know that herpes may be present in some acanthamoeba cases in the cornea, and who knows the potential role of Epstein-Barr virus that we've been finding it. It's very difficult to understand. How come these patients have also Epstein-Barr positive in the vitreous? We do not see them in other situations. We do not see them in diabetes. We don't see them, but then in tox, it appears.
Thank you.
We're doing study now. We're doing study now in iBank eyes. We're doing again the study that we did many years ago with better technology now, looking for tox as well as viral in the retina of iBank eyes. Let's see what's going to happen.
Yes, and regarding the question, the Justin's question, I think I don't have the certainly, nobody has the certainty. I have no idea also, but I think that could be possible to reinfect with different strains. The question is how to know which strains was the one that previously infected the patient, because we are seeing few patients that having IgM negative already, then they have IgM positive.
Mm-hmm.
So, why did this happen? Why this is happening? Isn't in a few patients, but that's why we are starting to think in the probably reinfections with another kind of strains. But who knows? It is complicated to prove, no, because how to know what was the genotype of the previous infection? This is the problem.
But you would be able to, if you could genotype, you would be able to
Exactly.
show that you had more than one parasite in the patient. Right?
Exactly, especially here in South America with different atypical strains. So, if it's possible, I think it's possible. And also, what Ruben said, that we are demonstrating also the possibility of the co-infection. And this is demonstrated by PCR in intraocular fluids. The theory for this is that interferon, the role of interferon gamma in the defense of viruses and also in the defense of toxo. So it's possible to have co-infections with mycobacteria tuberculosis and with viruses. And we have to think in atypical cases in co-infection also. So.
I would go further, not only for toxoplasmosis, but maybe other uveitis entities, such as BCH,
Exactly.
co-infection, the potential role of viral increasing interferon gamma and other mediators. And probably you have one uveitis that is caused by different etiologies at different phases. It's too bad that we do not have another 50 years of research ahead of us. I would love to do it.
100 years, Rubens.
100. I would need more than that, probably.
Yes.
Yeah, and we haven't even touched the gut microbiome. So it's so complex, so many confounding factors, right?
Absolutely, yes. So there is an interesting question here about EBV. We see EBV also in non-toxo uveitis or non-infectious. EBV may be in the B cells that enter the eye. It's true. In toxo, in immunocompetent patients, there is often a high influx of immune cells. This is true. This is from Yolanda de Groot Mohins. Thank you, Yolanda, for pointing out this. It is true. EBV lives in B cells. And when there is a disruption of the barrier, the hemato-ocular barrier, it is possible to have EBV inside the eye, inside the lymphocytes. But we have some patients that with atypical presentations that we have been treated with antitoxoplasma therapy. And then, because a PCR positive for EBV and toxo, we started combined therapy with antivirals, and the patients respond well. So who knows also? We have more questions than answers. But in these cases, not always EBV will be the guilty guy. But in some cases, probably it can be an amplifier of the inflammation and also a co-infected patients. We have seen EBV, for example, with a very important role in malignancies. Why not in infections or in co-infections? What do you think, Rubens?
I'm just saying that I never seen a patient with other etiology that had a positive Epstein-Barr in the vitreous. I've seen just in patients with ocular toxoplasmosis. So if somebody finds a positive Epstein-Barr viral in the PCR of the vitreous, it would be very important to report.
Thank you. And John?
I could just comment, when the blood retinal barrier is damaged, you might see other things appearing. And I think Jolanda said something to that effect as well in the comments. I was just meaning to ask those of you who've seen hundreds and hundreds of cases, I remember well one particular case I had that seemed to be very classic for toxa, but everything I did over more than a 1 year period didn't seem to quiet the retinitis. And I'm just wondering what you do in a case like that. This case was ultimately proven to be toxa, but it just didn't seem to be responding. So what do you do?
As I
I
told
would
you,
go for surgery. I would go
Yeah.
for surgery, remove the vitreous, look for something else. But I don't know.
Yeah, we did.
agree.
But anyway, are there I think that was before intravitreous therapy had become popular. Do you use that when you have cases that don't respond to systemic therapy or higher
Intravitreal
doses?
therapy.
Yeah.
Sometimes the patient might not be taking the systemic therapy, and
Yeah.
so and especially some of the younger patients, and intravitreal can be quite helpful. And there was a question in the chat about how often it might be given, and Alessandre answered that. But it's not unusual to require multiple intravitreal injections if you're going with that form of treatment. I don't know if any of the others would like to comment on how they use it, but I would expect to have to give it at least 2 or 3 times.
I would like to make a question to all of you who do have employed intravitreal therapy. I have a personal impression that it's not as active as systemic therapy for the patients who take it, as you said, Justine. Some are not compliant, they don't take the medication, so they would never improve. But I have the impression for the patients that I had solely treated with intravitreal therapy that, as you said, it does require multiple injections. In contrary, for what we have, for example, for viral retinitis that you inject, the response is very quick. But for toxo, I don't have that impression. I think it's something that you have to repeat. And so having said that, I do not employ intravitreal therapy as a primary treatment for these patients. Usually I do use it for the ones that are not tolerating systemic therapy or the ones that I'm concerned about non-compliance. And in some, like, for example, I recently had a patient, a pregnant woman, in the very beginning of pregnancy, like 8 weeks. And anything that we do, she would be concerned of having an abortion. So we decided she had just IgG, that was not a recent serial conversion for toxo, so just a localized process. So we decided to treat her just locally. She did pretty well, but I do feel that the response is lower than for systemic therapy. What are your thoughts on that?
I have the
am
same
not
experience.
a fan either.
No, I think that the point here is to treat the patients always systemically. I understand that in cases of pregnancy women, it is complicated, but we should treat always systemically, and intravitreal therapy is an adjuvant therapy, not the only one to use.
I've also used it as sole therapy in people who are very aged, who have a lot of other medical problems, and you really feel concerned about the effects of corticosteroid or even the antimicrobials. But again, having to give multiple injections, and it can really drag out. I think you're making a good point, Daniel.
Good. Well, I wonder if we should wind up because I think we're getting a little bit over time. Rima, did you have any summary comments?
Yeah, so I think we now we break for the webinars for the summer break. So after this, we now all of us meet in September for the next webinar that will be on ocular tuberculosis. So that will be our 7th IUSG Grand Round webinar. Global team, can we have the 7th Grand Round flyer? No, this is the current one.
Okay, ma'am.
So this is for all the experts and all the delegates and all the attendees. So we take a break, summer break till September, when we meet again on 7th of September for ocular tuberculosis. So we'll be continuing with the same format of having thematic lecture followed by case presentations and discussions by the experts. So till then, enjoy your summer break, all of you.
Yes.
And thank you all the experts, wonderful presentations, wonderful lectures, and wonderful cases.
And
Thank you so much.
Don't forget to send your
Thank you.
PowerPoint
Thank you.
to Alejandra, because she wants to put together the chapter later today.
Yes, yes, please. So send me your presentations and I will start to write the chapter and send the letter to you.
Thanks so much, Alexandra. It was really wonderful to be with you. Thanks a lot.
Thank you. Thank you so much,
you.
Justin, Rubens,
speakers.
John, and
Thank you so
Daniel.
much. It was fantastic.
Yes, thank you.
Bye.
Bye-bye.
All right, bye-bye.
Thank you. Bye-bye.
Bye.